I'm doing the session from a car today, so I just want to off the bat apologize in advance if there are any external sounds that are a bit disturbing. So Arya, let me know if that happens.
Sure, ma'am. Sure, ma'am.
Yeah, so we're still waiting for people to join. So as usual, I will ask for everybody to turn their cameras on if possible, and also to maybe put in a check-in word in the chat box. How are you feeling today? If a word is not coming easily to you, then a number on 1 to 10, 10 being good and 1 being not so good. So let's just get a sense of where everybody is. Oh, nice to see. Great. And 7, 8. Great. Generally upbeat so far. Okay. Can I request a few more cameras to go on? Especially those joining from Pallium, India, perhaps. Okay, so I know that last week you had a session with Rajika, and she introduced you to the basics of communication in the context of palliative care. So today I'll just take it a little bit further down the line, where we will talk about the more difficult issues in communication, and perhaps I'll also invite you to share some of your experiences as not just care providers but also care recipients, and when a time when you've experienced good and bad communication. So, Arya, we're waiting for about what, 10, 15 more people? Is that right? Yeah. Okay. All right. I can see a lot more people have just logged in. Great. Okay. So let's get started. Um, and would anyone like to share with me any takeaways from last week from your communication session with Rajika? Yeah, for those who are traveling, it's fine. Don't worry about switching on your camera. Any takeaways from last week, from last session? Anything in particular that you'd like to share with the group while we wait for more people to join?
I got good feedbacks. Uh, so please share it with the faculty also.
Yeah, it's good to know what feedback there was. Nobody? I know.
Dr. Shanmukha Priya, ma'am, can you share the experience?
Hello, ma'am. So it has been today. It was very good session. Actually, I was traveling at that time, but I'm happy I didn't miss the session. So it was about the active listening, the body language, and the models were explained, and even the question answer sessions later on also it was really good. We had two parts of the session, and the history taking. And we do had certain doubts like how to break collusion or the selective collusion, all those things. But we were assured that in the coming up sessions, in the advanced communication skills sessions, we will be able to address all those things. Yes, thank you.
Thank you. Anyone else would like to share any reflections?
Am I audible?
Yes, yes.
When we had the session in communications, such simple things that you learn, and they have been quite effective. So after that session, when I have been to the patient's house, usually I have a habit of sitting down and crossing my legs and speaking to the patient. But then I started sitting at the same level as the patient. If they're sitting on a chair, I would sit on a chair. If they were sitting down, I'd sit down. And I think that definitely makes so much of a difference in communication. So something really small, also the touch aspect of it. So it has definitely seemed to be quite amazing that something so small can actually do wonders, especially in therapy. So I'm a palliative care counselor. So Yeah.
That's really encouraging to hear, and I'm thank you for sharing that. Because yeah, it's these small things that seem so obvious at first, but then it's only when it's pointed out we realize how tremendously impactful they can be. So thank you for sharing that, and I'm really glad to hear that you were able to immediately apply something and see how effective it is. Anybody else?
Mr. Parag, can you share?
We're just going to call people's names out now.
So yeah, I mean, overall, I mean, everyone summed it so well. It's the thing is that touch was again a topic that was explored, and there were not many opinions that came, like opinions and counter opinions, and culture specific, and the social culture aspects of using touch in therapy, and then it opens another bank of things, stuff wherein how close and how much and things like that. So I think that was a topic that was discussed a lot during the last session.
Great, thanks a lot. And so yeah, so let's get started with today's session then. And like I said, when we just started, when others were logging in, we're going to be talking about slightly more advanced scenarios. And once again, some of you might be adept at this, and in that case, I will ask for your inputs as well. So, can I ask for a volunteer, please, to read out this case study? Anyone?
Mrs. M has suffered a severe stroke. It has left her in a semi-conscious state. Her chances of recovery are not good, but it is unclear how long she will live. Her husband is her primary caregiver and is confused. They have two daughters. One lives in a different city and travels to her parents occasionally. The other lives abroad. The daughters have a difference of opinion. One wants to focus on comfort care, the other wants to spend money on interventions and more doctors. They cannot agree on how to manage the father or the patient. What are the communication challenges for you as a care provider?
I haven't done this case study with you before, have I? Sorry, I'm a little confused. Okay,
No,
great.
no, you haven't.
Okay, great. This is a real life case, by the way. This is a real case. This is not a made up case. So just tell me what comes up for you first. There are no right and wrong answers. Feel free to unmute. Feel free to use the chat. So, what are some of the major communication challenges that you, as a care provider, are seeing in this, and what are some of the ways in which you will approach it?
So one is that since it's unclear how long she will live, it might be hard to. I mean, a lot of times, patients or in this case, caregivers want a definite answer about prognosis or how what kind of recovery the person will make or they want something definite when you might not necessarily be able to give that to them, and that therein lies the challenge, I suppose.
Yeah, that's a tremendous challenge. And what you're touching upon here, Dhwani, is prognostication, right? And prognostication is a skill that needs to be honed and practiced by healthcare providers, and not everybody is good at it because we're so focused on cure, or we're so focused on diagnosis and disease, that prognostication is a skill that it's like a muscle. If you don't like utilize it, it really doesn't work. And a lot of people are actually afraid to to give a prognosis because of what impact it might have on the family. And in this case, it is unclear. The situation itself is that it's unclear how long she will live. Okay, great. So prognostication and the challenges that come up from there. What else?
I was thinking of time and space as well. Like they are in different cities, different geographical space. At times, it could make a difference when you come together, sit together. It has a different impact, I feel. I am the one who's here taking decisions, and you people are just advising me from sitting in a different city. And that maybe that could be one of the challenges, and the communication, the back and forth, constantly happening. We live in the digital age, but still, I think it makes a difference when you sit together.
It does. And no, that's a brilliant point. Just the difference between communicating over the telephone or over, say, Zoom versus actually being present in the actual space where the care is taking place. What are you sensing in terms of prioritization in this family? And why do you think, what might be some of the underlying reasons for it?
They, no, I'm not sure if this is right. I mean, because both the daughters might not, are not actually living with their mother. I mean, in this case, the people who are actually not the primary caregivers have a strong opinion about what should be done rather than the person who actually is living with her and is looking after her all the time, that is her husband.
Yeah, that's right. And it's also, I think we've talked about this sometimes, that it's the people who control the finances who get to have certain opinions as well, right? Um, could there possibly be some guilt on the part of the one living abroad?
Yeah.
Yeah, that happens. Yes.
So she's not able to come down and actually do any bedside caring.
Mm.
So she's insisting on expensive interventions, right? Yeah. Also, sometimes people feel that we have money, so we should let her live.
We should be doing
Yeah. And
everything. Yeah.
if I'm not there to physically take care of her, I'm just going to spend as much money as possible and not really take into consideration. So, in this case, because it was a real life case that we were handling, and we had very long conversations with the siblings as well as with, and they were gatekeeping the father, by the way. They thought that the father himself was struggling with his own health issues and he should not have the burden of making decisions. So that was an issue that was coming up. And even the daughter who was living, so the parents were in Kerala, the one daughter was in Delhi, the other was in the US. And the one in Delhi said, I'm there, I know my mother, I can see that she's in discomfort, and all they're giving her is a paracetamol. I want to push for palliative care, but my sister who lives abroad doesn't understand it. She's saying she just talks to the doctors, and the doctors there are not, they're saying that no, she's in a vegetative state and she's not feeling pain. But I know my mother from the way she's responding to certain things, that she must be in pain, and I want to up the pain medication. And so that was a point of contention. They did not have a palliative care consult, and they were going by just the sense of, how much pain could she possibly be in? Is it necessary? Do we need to medicate? And one of the interventions that the sister abroad wanted to do was buy an airbed that cost about 110,000 rupees. And so what the sister in Delhi said is, she should just pay for my air tickets, because I'm the one flying down from Delhi to Kerala every month, and that's coming out of my pocket. So instead of paying for my ticket, she wants to pay for this. So they were starting to bicker about stuff like that, but you can see where they're coming from, right? So really, I think one of the challenges was them understanding, like Tony said, the prognosis, not having had clear understanding of what can be done, cannot be done. There's no palliative care consult to really assess whether the mother is in distress or not. Nobody's bringing the father into the picture, who is basically the primary caregiver. So there are various entry points into this conversation. We're not here to resolve this case. We're here just to talk about, to understand how complex communication can actually be. So here's another case study. I'm going to ask for another volunteer, please. And this is again a real life case. Would anyone like to read this out, please?
Yeah, I can go.
Please, go ahead.
Mr. J has been diagnosed with an aggressive and advanced form of cancer. He retains functionality and is not in pain. His wife was a dentist and is deeply religious. She believes prayer will cure him. Their only daughter works and lives abroad and is now visiting. She understands that his time is limited and she would like to speak with him about his wishes before she heads back. She doesn't know if she will get the chance again, but her mother doesn't want her to and stands guard over the father. The daughter is distressed that her father knows about his prognosis, but is not being given permission to acknowledge it and get his affairs in order.
again, so this this was also, and this was during COVID actually. So the daughter had one shot to come to India and spend time and go back. So even if she had the money, because of the travel restrictions, she's probably not going to make it back. And that's what happened. He died while she was away. We did manage to resolve it to a certain extent. But now here, major challenges. Let me start you off. Denial.
Hmm. Yeah.
Yeah, just think the wife's denial and the patient autonomy. So we also face the same thing. The patient wanted to know her prognosis. She knows that she has got a stage 4 cancer. But the whole family believes in alternative therapies, prayers, rituals, and all those things. And they guard her from the physician also talks only with the family
Hmm.
because of the culture. But the patients is again and again asking the palliative care team that she wants to know what is going to happen. I accept that this is karma and I don't have any problem in accepting my death. But I want to plan. I want to talk to my sons about certain things. I want to talk to my parents about certain things. So we had a conflict of the main issue was it was not integrated. We are separate. The primary physician, we don't have any contact with the primary treating team. So that was itself the integration, absence of integration of the palliative care team with the treating team is in itself a biggest challenge, I feel.
Hmm. So coming to this particular case study, uh, okay, we were the ones who were brought in as a palliative care consult. But before we came in, this was the situation, yeah. Now we have the denial of the mother on one hand. We have a sense of urgency in the daughter because she doesn't know when she's going to be able to return once she leaves. But this is classic collusion. And the fact that the mother comes from a healthcare background gives her a certain authority. But at the same time, her religious beliefs are at loggerheads with her scientific brain. And I mean, it happens, this happens. So she's got the authority as a healthcare person, even though if she's not an oncologist, but at the same time, she's calling the shots. Now, the daughter and the father both know what's happening, but they are, in a way, um, uh, basically, they don't want to upset the mother, right, by having this conversation. Okay, so lots of challenges. And again, we will talk about collusion. So at that point, we will come back to this case study and see how this collusion can be managed a little bit. Okay. The single biggest problem in communication is the illusion that it has taken place. I feel like I've said something to you. In my head, it's clear. You have received something entirely different. And this is always the case. I mean, and there's a huge risk for this, especially in healthcare, because as a healthcare provider, you think you've given the right information. The patient or the caregiver has taken something entirely different away from it. There could be many factors, just the emotionality of or the volatility of that situation, many things. And I think maybe Rajika might have touched upon certain barriers to communication in her session. So those things also come into play. Now, when just a few considerations before we go into the actual uh, well, the methods in which we can approach these difficult conversations. It's important to remember who communicates. The main caregiver may not be the decision maker. Like we saw in the case of that lady who is in a vegetative state. Her husband is the main caregiver, but he's not the decision maker. What to communicate? What are we going to talk to people about? The impact of treatment, concerns, challenges, and how to communicate. We have to be mindful of our verbal as well as non-verbal. And it oftentimes when I work with families who are at these crisis points of communication, I ask them to write down their concerns and questions in advance. It really makes a difference when you start putting it into actual words and writing it down. It's different from when you're thinking it in your head. So when you're thinking a thought and when you try to put it on paper, sometimes there's a little bit of a difference in what comes out. Also, it's a clarifying process for you also. And also what happens then is when we finally come together to have a conversation, it's almost like a checklist. We're making sure that no concerns are left out, because conversations can become tangential, and it can go off in one direction, and then people forget to make a point that they would like to address or whatever. And we have to be as specific as possible in these situations, and we have to be clear about facts, even if we are feeling emotional about it. Now, there are different levels of clinical decision making, and this is important when it comes down to getting a diagnosis, working with a prognosis, whatever else. We're talking about treatment options and so on. So at the outset, if I'm to simplify it, there is the medical communication, which is I give you information. um, these are what the test results show. This is what you have. This is the diagnosis. This is the treatment for it. Information. There's a slightly more paternalistic level where I give you the information and my recommendations, where I say, this is what the results show, this is what you have, this is the diagnosis, these are the treatment options, of which I personally recommend these in your case, because going by evidence, going by patients that I've worked with earlier, this seems to be a good way for you to go. But really, we're looking for shared decision making, which requires information, recommendations, and taking into consideration people's values and preferences. These are what the test results show. This is what you have. These are the treatments available. These are the treatments that have worked in my experience. But given your financial situation or given your capacity, what do you think works for you? Do you want this treatment? These are the side effects. Are you willing to live with these side effects? This is what it's going to cost you in the long run. Are you able to financially support that care pathway? So values and preferences, and this is where shared decision making comes in. Do we see shared decision making often? Have any of you experienced this? Or, I mean, I'd really like to know from you, what has been your experience in terms of medical paternalistic or shared decision making when you have been a care recipient, not as a care provider? Have there been examples where your values and preferences have been taken into consideration? Those conversations have happened?
It happened once for me, but this was in relation to my grandmother.
Hmm.
So she had pulmonary fibrosis, and she was being treated by a pulmonologist who would give us lots of do this. He was very authoritative. He would just tell us exactly what to do, get this result, give this medication, repeat this test. Then, as she was approaching the end of life, we requested a palliative care doctor to come in, and that was the first time we had a conversation about what we wanted and what my grandmother wanted as well. So until then, it was more, it wasn't even paternalistic in, it was more like, okay, do this. And that was it. And it was only after we began the conversation with the palliative care physician that we uh, got close to shared decision making.
So I think in the Indian context, we need to bring in one more, just authoritative and directive, because very often there's no room for any bilateral conversation, and so that's been I think it's safe to assume that majority of this group has not had an experience of shared decision making. Okay, so now also let's come to, when it comes to decision making, who decides? And this is an important aspect of advanced care planning as well. But even in without that, just regular day-to-day decision making about treatment and disease state and so on. So there could be potentially three different scenarios. One where the patient decides. And the patient can decide provided they have all the information and decision making capacity. Okay, so if they're able to make decisions, it's not just enough for them to have the information. Do they have decision making capacity? The other scenario could be, I, as a patient, will decide who will decide for me. My son will make the decisions for me. My husband will make my decisions for me. My children will make my decision for me. And that means that conversations have to be had in advance, preferably when people are healthy, if not at least when lucid. So that is ideally, that is a prerequisite. Okay. But very often in India, we don't have those conversations. We just say, nahi, nahi, my children will decide for me. And if there is someone who's even mildly related or associated with the medical field, 100% they should make the decision for me, even if they have nothing to do with the kind of disease I have right now. And finally, we have a situation where either the whole family decides together and there's no discussion, or nobody decides and we ask the doctor to make all the decisions for us. And this is also very common. And here the patient's wishes are not considered. And usually this kind of stuff leads to emotionally charged decisions being made during a crisis, which lead to conflict, which lead to difference of opinion, which lead to all kinds of things. So that's probably that is probably the unhealthiest sort of scenario where no discussions are really taking place. We're not having any conversations, and nobody is taking charge of the situation. Okay. Um, all right. Now, another consideration is, where do we want the care to take place? Where is the location of care? Is it in a hospital? Is it in assisted living or a nursing home or a hospice, or is it at home? And usually, we look at hospitals when it's an acute care setting, when procedural interventions are needed, when there's a close monitoring of symptoms that are required, and also affordability is a factor. When you have chronic advanced conditions, perhaps extended care in a hospice or a nursing home or an assisted living facility, not very commonly seen in India. We usually have more, I mean, I wouldn't even call them care homes, because the quality of care there is not very great. And also sometimes this happens when there is no capacity to provide care at home, because there might be just one other person in the family who needs to go out to work in order to make the enough money to pay the bills and so on. And home, provided there is access to support and if the family dynamic supports it. Okay, so and a lot of stuff can actually be managed at home, but again, these are not conversations that are had very frequently amongst people. And this is an important conversation, especially when we decide, okay, how much are we willing to spend? How much of this can actually be managed in terms of symptom control and so on at home? We don't have those conversations. Okay, now again, I'm going to invite you to describe a time when you did not feel comfortable or heard or understood by a healthcare provider. Can I just open the floor up to all of you? Um, we'll spend a few minutes here. Just really want to understand from all of you a situation where you may not have felt comfortable or understood by a healthcare provider.
Um,
Yeah, please
I
go
mean,
ahead.
this is, I mean, it's private information, but still, feel it's important to share it because I had a really bad experience when I visited fertility care providers who, not one of them ever asked me how I was emotionally feeling about having to go through that process in the first place, or what all the diagnoses and the results might have meant to me. So that was that. I grew up in an environment surrounded by doctors. They've actually always been my heroes, but that was the first time I felt really let down, and I failed to understand why something that was so obviously also an emotional issue was completely ignored by all the healthcare providers that I visited. No one ever asked me, "How are you feeling? What do you think about this? What is it? How are you going through How are you coping?" That was never asked once during multiple visits to gynecologists, fertility doctors, etc.
Thank you. Thanks, Swani, for sharing that. I mean, what that really sort of also highlights the fact is that sometimes it's not what is said, but what is not said also, right? The absence of compassion can be as cutting as the presence of, say, language that is hurtful. So it's a fine balance. And I'm sorry you had that experience. And, I've it's also even growing up as a young woman, I remember going to a gynecologist. It took me a while to land on the right gynecologist because of the sheer insensitivity of how anything would be approached, right? And as a 22-year-old being asked, "Are you married?" Like, you can just ask what you want to ask, right? But also the judgment that came with it. And I, finally, I realized, I mean, I have a gynecologist now for the last 15 years who is a man, and who is stunningly compassionate while being competent. So it's really, yeah, the lack of compassion can actually make an experience extremely distressing. Thank you for sharing that.
So
Anyone?
I have something to share. This is from as part of an international NGO based out of Mumbai, and this was a community health project, HIV advanced HIV project, and so there was this somebody who we had one of the patients who had come, and she was undergoing her sex change transition, the transition phase of her change, and then while she was consulting the doctor, she insisted that she be that the pronouns that she wanted to be used were she or and her, and still the doctor kept on addressing her as like in the male he, him, and his. So this also I think addresses what you asked. I think when you are not heard, not seen, when you don't feel seen by them, and the identity itself, because the social cultural aspect always fascinates me when it comes to healthcare. As to when, despite like you firstly you don't want to acknowledge what I'm trying to tell you, and what how then that automatically created a barrier, and it just went downhill from there. And so yeah, that was the sharing. Thanks.
Thank you. Thanks, Parag. Um, this idea of some people are not seen, or preferably not seen. And also we see this in terms of other gender uh, related issues. I mean, very often we'll see that the woman is the patient, but it's the husband who's being addressed. I mean, she's sitting right there, but all the questions, all the conversations are being had with the husband, or with the father or whoever. Um, happens with young adults as well. And children who are what 16, 17 years old, they're not even being asked anything. They're not even being asked how they're doing. The parents will be asked, so how is he doing at home? So yes, completely bypassing the person or disregarding their preferences. Yeah, that's another example, very good example of how we're not seen, we're not heard, and then how that becomes a unpleasant experience. Sakshi, I see that you shared in the chat, um, experienced a lot of stress during exams, and that's how I used to fall sick before every exam. There you go. Yeah. Prescribing medication without figuring out the underlying issue, or what is causing the anxiety, what is causing the stress, and just medicating, straight up medicating. So dealing with the symptoms, not dealing with the issue, and not taking it seriously when you try to explain it, right? Like, so this is also, this is what happens when when maybe a doctor doesn't have time, or they don't want to go there, because it means actually having conversations that are beyond medical conversations, and they don't want to do that. So anyway, thank you all very much for sharing such personal and um, you know moving experiences. So let's come back to this. Let's talk about bad news. And today we're going to be discussing this, how especially uncomfortable it is when we're giving bad news, and how what the experiences of the person who's receiving it, and how very often at this very important juncture is where communication fails us as healthcare providers, and where we could cause a lot of damage because we're not sensitively approaching it, either because of our discomfort with it, or because we haven't been trained in how to manage such a situation. So first of all, what is bad news? And bad news, let's start with this example. Okay. um any volunteers? Anybody? I just start calling out names. Yeah, go ahead, please. Did someone unmute?
Remark, are you trying to read?
Hello, am I audible?
Yes.
Yes.
Go ahead.
Okay. P is starting physiotherapy. He or she has had a bad stroke with left sided paralysis. Doctor, when will I get completely okay? Response, I'm sorry to say, but this cannot become completely okay.
Okay, that's one response. Go on, Seema.
He has been sent to a nurse to be given the diagnosis. Response, your report has come today and have been handed to me by Dr. X. You have cancer.
Okay, thank you. So, would you say either of these responses are uncommon? I mean, sometimes we're just, we in this case, it can't become all right. We're not discussing any different trajectories, any of that. But here the consideration might be that, okay, listen, I'm just being honest. We're going to save some time by just we're not giving him false hope. Now, in the second case, the doctor himself has clearly decided that he's not going to break the bad news and given it to the nurse to break the bad news. And the nurse has said, okay, this is what your report says. Again, there are no lies, there is no deception. But at the same time, do you think this will land okay with anybody? Okay. So, bad news is basically information which drastically and negatively alters a person's view of the future. Okay? Any information which drastically and negatively alters a person's view of the future. The greater the gap between someone's expectations and the reality of the situation, the worse will be the news. If I've been telling a patient, ha ha, sab theek ho jayega, don't worry, don't worry, don't worry, and then everything goes wrong, the the worse the news feels. Whereas if I have been sensitively, realistically taking a person through it, the shock or the impact of the bad news is little bit less. Okay. Now, my question to all of you, who is the best person to deliver bad news? Who is the best person to deliver bad news?
The doctor as well as the counselor.
Okay, doctor and counselor. Anyone else?
Can I speak?
Yeah, Meral, go ahead.
I think sometimes it could also be somebody who is close to the patient.
Okay.
Yeah.
To the patient, that could be a family member or a friend.
Yes, yes.
All right. Okay, so doctor, counselor, someone who's close to the person. Any other responses? Okay. Someone the patient knows and trusts. That's in line with what Miral has just said. It could also be the doctor. It has to be someone who has a skill of conveying the message. I might be somebody who the patient feels close to, but I may not have the skill to break bad news when it comes to a prognosis. Those who can handle reactions effectively. Now, I've given you the bad news very skillfully. You had a complete meltdown. I don't know how to deal with it. So I'm not able to close the loop. Those who know the disease, the prognosis, and the treatment, this would be someone like Seema said, the doctor or the counselor. So there are various people who fit this, uh, you know, the role. But I would say that the ideal person is somebody who is at that moment appropriate. Okay. Someone may not tick all the boxes. Now, when is a good time to break bad news. Which
Ma'am.
remember, yes, Kazin, you want to say something?
Um, yes. Am I audible?
Yes, please go ahead.
So, I also feel that, definitely these people are the ones who could break bad news. And maybe in some way, all of them can to a certain extent. It doesn't have to be all together, but in a very, how do you put it? Like initially, the doctor can give some idea, of course, in a very empathetic way, and then it can be taken forward by a relative or by someone who is trusted. So it doesn't have to be all at once in one go, all the information, because it's almost always is sometimes I would say very helpful when it's done in parts as well, from my personal experience.
Absolutely. That's an excellent point you've made. Thank you for raising it. And you're right. So this also is a series of conversations with an interdisciplinary team. And when I say team, I also include the family members in it. So that's an excellent point, guys, and thank you very much. Okay, when is a good time? Sharing information is an ongoing process. It's not done and dusted once and for all. Like you said, it's a series of conversations. So sharing information is an ongoing process. We have to remember that whenever the patient asks, and the patient might ask multiple times because it takes a while sometimes to absorb the news. And the patient might just come right out and say that, I want you to tell me right now what's going on. Now, provided the patient has been given the opportunity to ask, someone can only ask if that door is opened for them. And if we're going through a very authoritative, directive sort of way where we're saying this has to be done next, this has to be done next, without really discussing the results, without discussing the impact, without having those conversations, we're not really giving the patient an opportunity to ask for more information. And now I'm just going through a few, before we come to the actual protocol, some important things to consider. We need to make sure that when we have this conversation, we have to have a good idea of the medical history and the progress. The person having this conversation should have a good idea about this. So it could even be a social worker in the team who could be well versed with this whole uh, journey, who's been close with the family, who's been working closely with the family. We have to ensure that the environment in which the news is given uh, is correct. If you can't get a quiet room, at least find a place that minimizes disturbance. And in terms of people and personnel, it has to be done by those who know how to do it. And sometimes doctors are lacking in that skill, but maybe they need to have somebody there with them from the team who's able to provide a buffer or a cushion for this kind of information coming through. Okay. Now, framework. When I say framework, what do I mean? Typically, when you come into a setting, when you're having a conversation with somebody about, um, you know, about their disease progress or whatever, I say, okay, I invite the person to talk to me and I have to declare my agenda. So I would say something like, today I would like to discuss with you the reports of the tests which we did last time. Okay, I'm declaring what is the agenda for this meeting. But before I proceed, I must also invite the patient's agenda. Before we get started, I would like to hear what you are hoping to get out of our visit today. So why am I doing this? Why am I declaring my agenda and then eliciting the patient's agenda? Why is this step important?
To make it to convey the impression that, not convey the impression, but to make the patient feel that this is not just they are not going to be a passive recipient, but they are an active participant in the meeting as well.
Yes, that's one.
Also, we kind of understand if they have an idea or not about their condition with this, like asking them, would you like to, I would like to discuss the report. So if they might also say, okay, I don't want to discuss this. You could discuss this with my primary caregiver or someone, and then we would have to, somewhere respect that as well. So do they want to also talk about this? Is something that autonomy we need to give them as well.
Yeah, that's definitely an important part of it. Um, one of the main reasons I'm doing this, apart from ensuring that they know that they will be seen and heard, like Dhwani said, or like you said, that they have a choice. But also I'm doing this to match expectations. Okay, so I'm here to talk about the test, but also I need to know what's topmost on their mind. Now, I may want to talk about the test, but they might want to talk about the fact that they've been constipated for the last 2 days, or the fact that they haven't been sleeping properly. Now, can I have a conversation about bad results of a test if the patient in front of me is extremely discomforted with constipation? Is it a good time to have that conversation? If they're in any kind of physical distress or any other kind of distress, they haven't slept in 4 nights, is this a good time for me to be discussing their test results? So,
I'm sorry, I'm unmuting a lot.
no, no,
I
please
just
don't
wanted
be
to.
sorry. I'd love the fact that people are being interactive. Go ahead.
So in that situation, of course, that would not be the right time to kind of break the bad news. I'd like to just share one experience of mine. I was new. I was new into palliative care, and it would have been my first breaking bad news. So I was all prepared, and I had read a lot, and I was quite excited to, do it. I know that sounds wrong, but hello.
You are
Yeah, we can.
audible. You are
Go
audible.
ahead.
Yeah. So at that time, when we reached the patient's house, we kind of saw that the patient's health has deteriorated quite a bit. So we had to decide to, of course, then go against, breaking the bad news, because in that situation, the patient is not going to be receptive. And as Smriti ma'am also said, that's not the right time to share the news. So this happens quite a lot, especially in palliative care, because we do, see patients who are end of life, and, who we might not be able to, tell them as well. Ma'am, you're on mute.
Yeah. So I was saying thank you for sharing that. It reminds me of the time when I was a novice, and actually not just as a novice, even now, every time breaking bad news requires a certain amount of prep. And sometimes you're like, okay, especially if it's with a patient that has been in your care for a long time, or a patient with whom you're trying to establish rapport, you prep, you get ready for it, and then you go there and you realize that it's not happening, or the person is not being able to receive it. So I also understand where you come from when you say, you're looking forward to it so you can actually be done with it. Um, so when I declare my agenda and the person's agenda is different from mine, I have to then negotiate the agenda, which means I have to see what is important to them and how I can manage that before I get to where I want to take this conversation. And that's also important because especially if it's a conversation about prognosis, I need to have it at some point or the other if the person is, not deteriorated to the extent where they're unconscious or something. So I might say something like, there may be more, on your list than we have time to discuss. What items do you prioritize as most important? So they might say, yeah, I've not been sleeping well. My appetite is a mess. Uh, you know, I'm quite anxious, things like that. So they start listing out various things that they are experiencing, which is causing them distress. So I need to then say, okay, what is of priority to you? So that way, like what we talked about initially, they have a place to be seen and heard, and I am listening to them. It's not like I'm simply asking them and then moving on with my own agenda. Then I take care of what is important to them. So if they're saying, okay, I'm having trouble sleeping, then we need to talk about that. We need to address that on priority because that is priority to them. And once we've reassured them that this is going to be taken care of and give them some kind of relief, then I can move on to my agenda. But this is a pressing issue. Um, then I need to have a discussion with the team, see what I can take care of immediately, and then how I can proceed with what I need to tell them about, the news that I have to share with them. Um, you might need to invite other decision makers. And how does that happen? You could say something like, who do you usually rely on to help you make important decisions? By saying this, I'm also letting them know that they have to make an important decision. An important decision is coming up. And when we discuss your results, who would you like to be present? Now, this is something that I need to say before I set the appointment, right? They can't be in my office and then I say, who else do you want present? They may not be available. So, depending on the kind of family that you're dealing with or the patient that you're dealing with, you might want to invite other decision makers. And this will give you a sense of where they are in terms of how ready they are to receive the information that you have to share with them. Because implicit in these statements is the fact that something big is coming. Now, we also have to understand, is more information wanted? Now, we must not withhold information if the patient or relative wants to know. But at the same time, we do not impose information when the patient does not want it. If the person says, I don't want to know, doctor, I think whatever's happening is happening now. I just want to make sure that I'm not in pain and just give me some pain relief. That's enough. The conversation should end there for the time being. If you feel that it's important, then we can broach that subject again later. But if this person has given you clear indication that they don't want to take this conversation forward, it is fine. We are not under obligation as palliative care providers to tell the truth at any cost. I'd just really like to make that clear, because sometimes we pay a lot of we put a lot of emphasis that no, it's important to tell the patient the truth. It's important to tell the patient the truth. But if the patient has made it clear that they don't want it, we have to respect that, and that is absolutely fine. I'm just going to take a second to look at the chat box because I see quite a few. Yeah. Okay. All right. Yes. So so moving on, we also have to check. Now, we have to check patient's understanding. Tell me what you know about your diagnosis. And we talked about this, I think, earlier, where someone might know the name of the diagnosis, but may not know what it exactly means or how serious it is. Check patient's medical knowledge. Okay. So we have been talking about interstitial lung disease. What do you understand about this condition? And patients' understanding, okay, of um, their journey so far, as you ask them to recount it, you get a sense of well how how ignorant or how tuned in they are to their present condition. And specifically, we want to check medical knowledge because, like I said, we're so familiar with the jargon, but we may not be familiar with what actually lies behind that jargon. We need to check the patient's preference for information. How much do you want to know? And I'm coming to that protocol in just a minute. So, how many people here are familiar with the spikes protocol? I'm just going to stop sharing for a second so I can see the screen. If you're familiar with the spikes protocol, please give me a thumbs up or a... Yeah, Shanmugapriya, you want to say something? You have your hand up, or is that to say that you're familiar with the spikes protocol?
It's just to say that I know what it is.
Okay. Okay. Anybody else? Anybody else familiar with the spikes protocol? I see Miral, Seema. Okay. So majority are not. Okay. So let's go into it. This is typically the protocol that we use in breaking bad news and also in difficult conversations. SPIKES is an acronym. It stands for setting, perception, invitation, knowledge, emotion, strategy, and summary. And the setting basically means where we provide privacy and we give the patient our full attention. Perception is to understand how the patient perceives the medical situation, what I just talked about. What is the patient's understanding and whether they understand the medical knowledge, what is their medical knowledge of their condition. An invitation, ask the patient how much information he or she wants. Um, And we can do that also through going through that declaring agenda and negotiating agenda, and provide information tailored to the individual. That's knowledge. Emotions, we have to respond with empathy, and we have to respond to the emotions of the patient. And strategy and summary, when the patient is ready, present treatment options and make decisions together. So this is the overall spikes protocol. I'll just take you through each one of these in a little bit more detail. Setting. Now, first of all, we have to ensure comfort. And one of the first things we do to ensure comfort is introduce ourselves. Um, Introducing ourselves is really important, but we often don't do it because our name is on the board, right, on the door. So it's the patient and the family's responsibility to know who they're coming to speak to. Why should I introduce myself? But this adds to it worsens the power dynamic. This is as bad as sitting down and keeping them standing. So the first way to ensure comfort is introduce yourself by name and role. I am so and so, and I am the doctor, nurse, counselor, blah, 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 in charge. And I'm here to talk to you today about this. This is this is assuming that it's the first time you're meeting the patient and the family. And this happens a lot, that the first time you meet somebody is when you also have to break the bad news to them. Addressing the patient by name. Finding out the caregiver's name. I can't underscore this enough, because hardly ever does anyone address the caregiver by their name. If you do this, you will also win the trust of the patient. Because this small act is basically demonstrating that you care to know them as human beings. You're addressing them by name. You want to know, ye aapki kaun hai? So those kinds of things, that shows consideration. Offer them a seat or go to a quiet place. Remove distractions. You can what helps is if you can actually put your phone on silent and put it face down, and that also conveys non-verbally to the patient that they have your full attention. Okay, so ensure comfort in the setting. Perception. Assess how the patient perceives the medical situation. So first, I want to assess the emotional state. How are you feeling right now? Given the situation, what are you thinking about? So let's say it is that it's a patient with advanced cancer, and let's say that he or she has now gone through first line chemo, and basically what the results are now showing me is that the chemo has failed, so we have to move on to second line. So if I ask this question, what are some of the responses I might get from the patient? How are you feeling right now? Given the situation, what are you thinking about? What might the patient respond by saying? मेरा कुछ नहीं हो सकता, डॉक्टर ने बोला है. No, Payal, I'm the doctor. I have not said anything yet. How are you feeling?
Nervous and confused.
I'm feeling nervous and confused. Okay. Given the situation now, what is the situation? We've just finished our first round of chemotherapy. We've just checked how well that chemotherapy has worked. So given the situation, what are you thinking about? Okay, I feel anxious. Meeral says, will I become okay? Okay. What else? I'm worried. I'm worried about the test results. Okay. Now, find out what the patient already knows. What do you know about what you are experiencing? What have you understood from what you have been told so far? Okay, so this is the next step. So I first assess emotional state, then I try and find out what the patient already knows. How much do you know about what is happening to you? What do you know about what you are experiencing? Okay, so we've just finished first line chemo. I'm asking this patient, what do you know about what you are experiencing? What are some of the responses you might get? Kaizen, do you want to share any experiences that you might have had here?
Not that I can think of at this moment immediately, but I'll come back to you.
All right. So, what do you know about what you are experiencing? So, someone might say, well, I know that the medication that was given to me was quite strong because I felt so nauseated every time I took it. So, I'm really hoping that it has worked because what the doctor said to me was that was the recommended treatment for the disease that I have. And what have you understood from what you have been told so far? Um, well, given my experience with the chemo, I guess what I have is pretty serious because the treatment seems so intense. So there are a number of responses that you might get to what do you know about what do you have. Okay. Or you might say, chemo will be given. So I was told that I'm going to be okay once I've had this chemotherapy. That could also be one of the responses. You're right. Now, they might say, I'm feeling fine. I mean, the doctor, I've done my research and I think I'm going to be okay. And this could be very, very diametrically different from actually what the real situation is on the ground. And what you might see in some people is denial. No, everything's going to be fine. I trust my God. I've been praying every day, and I know I'm going to be okay. So I'm fine. Now, if it is the first time you're meeting this patient, please do not try to address this denial. Take another tactic. Don't say no, but don't you think that what you've gone through is like quite serious? Don't try and get past that denial at the moment, because if it's a long-standing sort of relationship, you might want to handle it differently. But in this moment, if this is the first time you're meeting a patient, please don't try to address their denial. Okay. uh सोनाली बेंद्रे युवराज ठीक हो गए तो उनको भी तो कैंसर था. Yeah, yeah. Yeah, they will respond to you by referencing celebrities and so on. Okay. Now, coming to the third part, invitation, asking the patient how much information he or she wants. Okay. Now, is there anything that you'd like to know more about? They've told me how much they understand. They're telling me what their sort of expectation is from the chemotherapy and so on. Now, what more is anything specific that you would like to know more about? Do you want to know everything that is going on, or do you want to focus on treatments? So these are just some sort of guidance questions that I'm giving you, where this is how you start inviting people to have this conversation. And to find out if the patient wants to know, you could ask something like, are you someone who likes to know all the details? Or is there someone else you would like me to discuss the treatment plan with, or do you want to talk to me alone? That will also tell me to what extent the patient is ready to receive that information. Okay. Now, there is something called a warning shot. Now, even if the patient says, I'm somebody who likes to know everything. I don't need anybody here. I'm happy to have this conversation with you alone. Now, they've given me permission to proceed, but I still have to give a warning shot. So my warning shot is something like, things are not improving as we quite hoped. Would you like to know more? So I'm giving them one more chance to prepare themselves for the news. At this point, if I've said things are not improving quite as we hoped, oh, okay. Suddenly, maybe I don't want to receive this news on my own, or maybe I don't want to receive this news today. Would you like to know more? So I'm giving them one more chance to exit from this conversation if they want to. Now, some other examples of warning shots are, it is more serious than we thought. We were not able to dissolve the clot. The results of the tests are not what we hoped for. So these are warning shots without actually saying that the test results are bad. I'm actually inching my way forward, or I'm giving these sort of warning shots. Now, at Payal, I'll come back to this example, okay? Because I don't want to digress from this flow at the moment. So I'll come back to that question. Arya, can you please make a note of it? The results of the tests are not what we hoped for. We're not able to resolve this. It's more serious than we thought. Now, by saying these things, I'm also giving them time to process the fact that, acha, what is coming next is going to be unpleasant. Now, then the patient says, okay, it's fine. Just tell me. Um, you have to remember to deliver information as per the needs and preferences of the person. Firstly, try and use the patient's primary language if possible. If the person is more comfortable speaking in Hindi, English is something that they struggle with, then it's best not to speak to them in English, because you want to minimize misinterpretation as much as possible. And a lot is lost in translation. Okay. And use a similar vocabulary to the patient. So if the patient has called their tumor a growth all this time, refer to that tumor as a growth. Don't start calling it a tumor. Okay. Give information in small chunks and clarify understanding every time. So I might say, so we did that first round of chemo, and if you recall, the doctor said that we're going to have to do 8 cycles and then see how the growth is responding to the medicine. And from what the results are showing, it's not responding as well as we had hoped, and the growth is increasing. Now I will stop there and let the person digest it, and then ask them if they have if they have understood what I mean. Yeah. So the growth is increasing. So you understand that this particular medicine is not working on it. Is that, am I being clear there? And if you can get them to paraphrase it back to you. Okay. Please avoid medical jargon. We don't want to start using medical jargon now, because this is a very, very sensitive time. And again, we don't want any room for misinterpretation. And state issues relevant to the patient honestly and clearly. So the growth is increasing, and here is what we need to be prepared for. We need to probably now explore the second line of chemotherapy. Now, second line of chemotherapy means that we're going to have to start over, and we're going to have to see if a new set of medications will work on this growth. What does that mean? You're going to have to come in for chemotherapy once every 2 weeks. Okay, so now you are going into the actual what comes next. And again, please keep pausing, stop, see where this conversation is landing for the patient. Now, sometimes I had my hopes so high up on this chemotherapy, because everything the literature tells me or Google tells me, they say this is the best medication for this particular kind of disease, and suddenly it's not working on me. So even if I'm not visibly crying, or if I'm not showing my emotions, there is an internal storm going on. I'm trying to grapple with this information. If this medicine doesn't work for me, then what if the other one doesn't either? So if I have this internal conversation happening in my own head, my ability to receive information from my care provider is limited. So that's why I'm going to keep clarifying. I'm going to keep pausing. Are you with me? Do you want to, what have you understood from what I have just told you? And let them respond back to you. So you know that they are receiving the information the way that you have intended it to be received. Okay. Now, the gravity of the situation has sunk in. And, or it could be a situation where I'm telling somebody that, from here on out, your mobility is affected and you're going to need to use either physical aids or a wheelchair or something. It could be the cancer diagnosis is just one example. There could be any number of points where we're breaking bad news. Now, I've delivered the news. They are absorbing it. Now I want you to explore and identify what emotions they might be experiencing. And in order to do that, I will ask questions like, what's going on in your mind right now? Or I might say, what is your biggest concern in this moment? Now, someone who was very brave and stoic up until this point has suddenly gone very quiet, at which point I might also ask, is there anyone in your family you would like us to call for you, to talk to? This is also giving them a chance to sit with what they are receiving at this moment. Identify cause, emotions, and link. Now, the results must have come as a shock. Losing independence must be upsetting. So now somebody is shocked by the uh by the news, right? Like, my God, I thought this was going to work. I can't believe it. So you're linking it to the fact that, okay, the result has caused this kind of shock. And yes, we know that we were expecting better results, and the fact that the results have come out differently, I can see that, I can understand why it's shocking. Or the fact that if somebody has to now, they can no longer drive. Unfortunately, your disease has progressed to a point where it's no longer safe for you to be driving or to be walking by yourself, because maybe there are mobility issues and so on. Losing independence must be so upsetting. You're actually saying losing independence, that is what is upsetting you, and I'm acknowledging that it is upsetting. Okay. And then I empathize. I'm sorry, I know you were hoping for better news. Or you could say something like, I can only imagine how difficult this must be for you. Or you can say, this must be very difficult for you to hear. It's just acknowledging the fact that this is upsetting, that you were hoping for better. So you're not trying to fix anything. You're not going to say stuff like, don't worry, we will take care of, we will find other ways to cure you. We're not doing that. We're saying this is difficult, this is hard, and I know this is hard. And by doing this, you're also deepening your connection and your relationship with your patient. And also, what we want to do at this point is we want to reassure. So I'm just going to go back. We want to explore and identify the emotions. We want to identify what has caused this emotion and link the two together. We will then empathize and sit with them and acknowledge that they're going through a difficult time. And once we have done that, we will also reassure. But reassurance is not that we will cure you. Reassurance is, we will do everything we can to help you. We will do our best to take care of you. You are not alone. We are here with you. We will talk to your family regularly. This is also reassurance, but you're not promising that you are curing them. Okay? You are reassuring them of your presence. You're reassuring them of your availability, of the fact that you are accessible to them, and that you will continue to provide the best care possible. And please be careful not to overpromise or to provide false reassurance. I cannot stress on this enough, because there is this tendency that we want to rush in and fix something, and we in that bargain, we right now this person is starting to cry and it's getting difficult for us, so we want to diffuse the situation. So we say, yeah, but don't worry, there are other avenues open to us. So sometimes the discomfort is coming from us, and we want to quickly put a band-aid on it, and we end up saying something that in the long run could be damaging. And finally, strategy and summary. When after you've gone through all this, okay, so you've declared your agenda, you've checked with the patient whether they want the information, and depending on what they've said to you, you have given them the information in chunks, in bite-sized pieces. You've let them sit with the information. You've then identified their response to it by way of the emotions. You've empathized with them. Now we're coming to what next. So I will summarize. So when you came into here today, you told me that these were your concerns. After which we discussed your test results, and we found that, the reports indicated that the growth has not responded as we expected, or the fact that, okay, your disease has progressed to a point where it's not safe for you to be, living on your own, or driving, or moving around by yourself. So at this point, what is acceptable to you in terms of care? Now, if you are not able to drive yourself or not able to live alone, um, would you be willing to have somebody live with you as an attendant? Is that acceptable to you? What is not acceptable to you? Or when it comes to the chemotherapy, would you be willing to accept another line of treatment? And what comes with it are these sort of side effects. What is not acceptable? What would you like to be able to do? And what is a priority to you? Um, Now, these seem like very simple questions, but please understand that this is a very key box. Because now, when we create goals of care, we're also setting expectations going forward, not just for the patient, but also for ourselves. I might want to now recommend that, yes, please go all out, get this therapy. But I have to sit, this is where I'm eliciting the patient's preferences. What is acceptable to you at this point? So it might be acceptable to me to have an attendant. What may not be acceptable to me is to completely lose my independence and my privacy. So I might want to hold on to some aspects of that. Okay. What would I like to be able to do? I'd still like to be able to go for an evening walk. And okay, fine. If I can't do it by myself, then I'd like, and I have to accept someone comes with me, fine. But I want to be able to do that evening walk. I don't want to be moved to a care home. I will not be a burden on my children, but a care home is not acceptable to me. Maybe, I can just uh, hire someone to live with me, and I can still retain my independence. I would like to be able to still visit my children once a month. Okay. And if I'm going to be doing this chemotherapy, then I might not be able to do that. So I'm now weighing out what are the goals of care. And especially in advanced illness, what the patient wants is very, very important. Okay. And facilitate shared decision making. Now, what we talked about earlier, shared decision making is eliciting, giving them the information, giving them recommendations, and then eliciting their values and preferences. So here are some options open to us. Okay. There are agencies where we can get a home attendant for you, but it's going to cost this much per month. Alternatively, we can get, if your help at home is willing to be trained a little bit by our telehealth team, then once a week our telehealth team will check in with your attendant, and on a video call we can talk about addressing simple issues. Okay, like changing of body position, or changing, or helping with toileting and mobility issues and so on and so forth. Okay. The other thing we can offer is we can schedule an appointment with so and so specialist on such and such date. That is an option open to us. Would you be willing to see that specialist? Or we have there is a social worker on our team who might be able to help you with your living arrangements, or to now help you get that caregiver pension for your attendant. Now, if you choose this, then this is what the next steps are going to look like. But if we choose this, so now a question around this could be location of care, right? So, okay, now from now on, it's unacceptable to me. I don't want any more hospital admissions, doctor. Now, whatever time is left to me, I want to spend it at home. Okay, now if it's lung disease, if it's interstitial lung disease or something, then I might have to say something like, okay, in that case, we're going to have to think about getting an oxygen cylinder at home. If you don't want to keep coming to the hospital, then we need to be able to manage your exacerbations at home. In order to be able to manage those exacerbations at home, you need to have access to at least 2 oxygen cylinders, so that any point you have an emergency, there is one that is full. Your attendant will need to learn how to switch between the concentrator and the cylinder. You need to know what is your distance to the nearest hospital and how much time it will realistically take you to get there. That will help us decide whether you need a hospital admission or not. Okay. What are some of the emergencies that would come up? This. In order to deal with those, this is what we need to keep at home. Okay. So there are a variety of directions this conversation can go in. But what we're really doing here is eliciting their preferences and coming up with a problem solving technique where both of us are problem solving together. I'm not telling the patient what they should and shouldn't do. I'm saying, if this is your preference, then this is what we need to be prepared for. Okay. So now in all of this, there's a very good chance that the information is not going to go down well. You might be met with denial. नहीं ये हो ही नहीं सकता. Absolutely not. I think you've got somebody else's results. Please go and get it checked, or let's run the tests again. Or you might be met with absolute silence. Have you been in the presence of that really like unbreakable silence? It is terrifying. It is terrifying to be in the presence of somebody who is just not even telling you what is going through their mind. Okay? Anger. No, no, you have messed up. There's something wrong here. You guys have not done your job properly. I knew it. I should have gone to that other doctor. Or emotional distress. How can this be happening to me? I'm just in my 40s. How can this be happening to me? Okay, you know what, doctor? Actually, how about we, let's try and do one more round of chemo, na? Maybe something else will happen. Shall we, or you know what if I come and just get admitted in the hospital and then you monitor me here for a little while? Maybe that might improve the outcomes. Maybe I'm not getting hydrated enough when I'm at home and I need like to be monitored in terms of my nutrition. So I'll come here. Let's just admit me. I'll be here and then, we can work it out in the hospital. So all kinds of these sort of arguments and bargains and all that will be tried to be struck. Or if you're very lucky, there will be acceptance. If you're very, very lucky. Now, I'm just coming to, it looks like a busy slide, but let's not be intimidated by it. Would anyone like to please read out this clinical narrative for me? Somebody who has not spoken so far. Akanksha?
Yeah.
Please go ahead.
Mohan, a 40-year-old presenting with pain for a month and incessant vomiting for the last 2 weeks, comes to the OP. Recent investigations indicate malignancy. He has 2 children who are 8 and 10. He lives in a joint family with his brother's family. He's been asked to do a CT scan but cannot afford it. His wife is anxious but doesn't pay much. His brother, who accompanies him, is upset that the patient is only worsening. He's also supporting the family financially. Mohan asks you, what is going to happen next? How much is the treatment going to cost? Am I dying?
Okay. Now, here is the case. Thank you, Akanksha. Here's the case. Now, we just went through this setting, perception, invitation, knowledge, empathy, summary, and strategy. I want you to go through each of these steps with me now when it comes to Mohan's family. And I am not going to give you any responses. So we'll go step by step and you're welcome. I'm going to give you some time to craft your thoughts. I've given you some prompts and sentences for each of these, yeah? So firstly, let's take setting, ensure comfort. So only that, let's not look at any of the others. Setting. So take a minute. If you have a pen and paper, please pull it out. And I want you to actually write down the sentence that you are going to say to Mohan and his family to ensure their comfort. Let's assume this is the first time you are meeting Mohan. Okay, you're meeting him for the first time. You're meeting the family for the first time. Take a minute and write down 1 or 2 sentences that you will say to Mohan to ensure or at least try and give them some sense of comfort. Okay, I'm going to give you a minute to do this. And in a minute, I'm going to come back to you for all your responses. Okay. Anyone? Please use the chat box. I just realized we're very close to closing time. Okay, sorry about that. Okay, so any responses? First time you're meeting Mohan, what will you say to him?
Those who are ready, please volunteer.
Um,
Go ahead, Akansha.
Yeah, so I'm going to introduce myself. I'll say, hi Mohan, I am Kansha. I work as a social worker with the geriatric care unit. And I work with whoever their doctor is on their team. And then I'll ask the family if they're comfortable sitting with me here and talking.
Excellent. That's lovely. Thank you very much. I'm going to encourage others to, rather than describe what you will do, to actually use the words that you will use. Okay, so instead of saying try to build a rapport, Febby, I'd love to hear from you what that sentence is that you will use to build that rapport. Okay, so what Akansha just did was fantastic. She introduced herself. She talked about her role in the organization, so that gives her own credibility. And then she's asked them whether they would like to sit down and have a conversation. Okay. Now, how do you feel now? Well, we'll come to that later. Yeah, Nanda, not quite yet. We're here. We're meeting Mohan for the first time. We're introducing ourselves. We are inviting them to sit down. Let's go to perception. Assess emotional state and find out what he knows. Yeah, so now that's when Nanda, how do you feel now? What is going on with you? That is the question that comes now. Any other responses?
How are you feeling today?
How are you feeling? Okay. Um, yeah, okay. Now, Mohan has asked you what is going to happen next. How much is the treatment going to cost? Am I dying? Now he's got all these questions, and now he's probably when you ask him how are you feeling right now, he might say, I'm feeling very anxious. They've asked me to do a CT scan, but I don't have the money for the CT scan. So that is my response to you. How are you feeling now? I'm saying I'm confused. I don't know. Where am I going to get the money to do the CT scan? That's my response. We're still on perception, guys. I've told you my emotional state. I'm upset. I'm Mohan and I'm upset. Let's go to the next. We're still at perception. I've told you I'm anxious, but I haven't told you how much I know. Maybe it'll help if I go back a few slides. Okay, so you know Mohan's story, right? And Akanksha has done this quite well, where she has introduced herself. She has offered me a seat or to go to a quiet place. How are you feeling right now? Nanda has asked me, so has Seema. I have told you I'm feeling extremely confused and anxious. I don't know where I'm going to get the money to pay for the CT scan. Without using these exact words, how will you proceed with Mohan? Because I'm giving you the guidance right now on your screens. Please remember, Mohan is there with his wife and brother. Brother is the person paying for everything. Okay? Given that I've told you that I'm confused and anxious, where will you take this conversation next? Ask Mohan what did his doctor say, or does he know why he was asked to take a CT? Excellent. Thank you. That's a brilliant next question. So you have asked me, what did the previous doctor tell you, and why has he asked you to do a CT? वैसे तो he's not told me much. He just said that, I'm just the CT scan will show me exactly what the problem is so that the treatment can be decided. But he's not said anything more than that. Anything else? So we could actually maybe then use one of these questions, right? So, okay, he's not told you more than that. So, tell me, what has it been like for you the last, when did you first start? Why did you go to the doctor in the first place? You know, I was having this pain, and initially, so I went to my local doctor and he gave me some medication, but it didn't quite work. So the pain kept increasing. After that, you know, I had some other difficulties. So finally, I went to this doctor, and then they said that, you know, they need to do some more serious tests. And so I've done a blood test, I've done all of that, and I think there was some abnormality in it. So now this doctor has told me that, you know, it looks like it looks like there might be something more. So he's asked me to do the CT scan. So at no point has it become clear that any doctor has had any conversation, right? Now, but judging by who he has gone to and the escalation of this, it sounds like something they're looking for a malignancy, right? So patient doesn't know much. Okay, so now we talk about what would you like to know more about? Now, I'm looking at the results. I'm looking at, and the CT scan. See, the previous doctors also asked them to do more tests. Doing more tests is also a way of buying time and postponing. If the other tests have indicated that there is a malignancy, maybe as a doctor, I'm not very confident right now to, I mean, I haven't gotten an exact prognostication diagnosis, but at the same time, I'm also saying, no, we'll do one more test, we'll do one more test, we'll do one more test. Now, me as a provider, it seems to me that things are not looking very good. And now at this point, he's also confessed that he has a issue with his finances, and the wife is also there. So I might also at this point look at the wife and ask her a little bit about how she's feeling and why she seems so anxious. It's a good time to involve the other people in the room in this conversation as well. Now, this is what I've got from Mohan. But I might want to ask the brother and the wife also what their experience of this journey has been like, to get another perspective on it. Okay. Now, again, I'm not going to go into these specific sentences when I'm talking to Mohan, but I might then say that, okay, you know, yes, actually, the reason for your CT is that it will help us determine the extent of your disease. And I can tell you a little bit more about what we are suspecting. Would you like to know that? Okay, so I'm not saying you have it. I'm saying tests indicate that, yeah, it is. I mean, you know, there are some indicators that it might be a certain specific kind of illness, and maybe why the CT is necessary. I can explain that to you by telling you what some of these suspicions are that we might have. Okay, and the warning shot might be that one of the reasons the CT has become necessary is because you haven't been feeling any better in spite of the medication that you've received so far. So that tells me that things aren't going the way we exactly wanted to. So that's a warning shot. Okay. I know I did say that I'm not going to give the responses, but anyway, in the interest of time. Okay. Now is when I will start to give this information, and I'm just going to go forward to Mohan's case. I will say, you know, this kind of pain coupled with this kind of vomiting usually tells us that there is a problem with um, this part of your body. Now, I'm not a doctor, so I'm not going to get into the specifics, but I will say that, okay, and if it hasn't responded to these medications and so on, then obviously it is not this. And recent investigations could also be what? He's had an ultrasound, he's had some blood tests. So I'm going to go over those reports with him and say, okay, what it indicates here is that these things are not in their normal range. What that means is that this is not functioning properly. Okay, so I'll go through it step by step, clarify it, wait for him to digest that situation, say, okay, this is possibly where the pain is coming from, and and this could be a possible reason for it. Okay, now also I'm going to I'm going to try and make sure that all three people, the wife, the husband, the wife, and the brother and Mohan, all are on the same page. So I need to check their understanding as well. Um, Now, slowly, I'm going to get to the point where, yes, this is actually quite serious. And the reason we want to do the CT is because we suspect that it might be something that requires much more serious intervention than what we've been doing so far. And that's why we need the CT to confirm that. And at this point, I need to sit down. This is where probably Mohan is going to ask me, am I dying? How much is it? And the brother might ask me, how much is the treatment going to cost? The wife might ask me, what is going to happen next? Okay. And at that point, I have to express empathy and say, yes, I know this is all very confusing at this point because we don't have any real answers. We don't know exactly what it is that we're dealing with, but we do know that it is serious. And yes, this can be very upsetting. And as in these conditions, finances do tend to be a problem. So we're going to have to try and find ways where we can give you good quality care with what is affordable. Okay. So summary and strategy, again, we're going to have to go back to the beginning of the conversation. You talked to me about your pain. You talked to me that you were vomiting for so long. You've been in fair bit of distress. And going by your results, these are some of the findings that we have. And this indicates that this is why we need the CT. We're hoping for the best, but at this point, things are looking pretty serious. Now I have to talk about what to do going forward. Try and do some problem solving in terms of how we can um, find the funds to do the CT perhaps. Maybe the brother does have the money, but we're going to figure out whether he's willing to actually do this in the long run. But we also need to talk about the fact that, okay, some of the things that we can help you with immediately is the vomiting. We can try and deal with those symptoms right now that are causing you so much distress. We can try and deal with the pain. You might need to be admitted in the hospital here with me for a couple of days so that we can manage this. This is a palliative care unit, so you can be assured that the treatment here is not going to cost a lot. And at the very beginning, what we can do is take away the pain and ease your vomiting a little bit. So that reassurance is also there. And we can tell the wife that, yes, there is a space here for an attendant. If you need to spend the night and be here, that'll be great. And so those are those immediately solvable things we are dealing with. Okay. I know that we are running way over time. So I'm going to be sharing these slides. And if you want to revisit this particular spikes protocol, we can maybe do a special half-hour session or a 45-minute session outside of our modules. Okay. Very quickly, I'm just going to deal with one more thing. When the patient or the family is angry, we have to make time to listen. There are ways to de-escalate it. We don't want to quickly come into blame or to over-explain ourselves. What we also need to do is move them to a private space or encourage them to sit down. Sitting down as an act itself de-escalates the situation. Also, it's much harder to throw a punch when you're sitting down. And looking beyond the anger to the fear and to the grief that the person might be feeling. Remember, behind anger is fear, is grief. Okay. So try and in that moment, don't be so like daunted by the anger that you're failing to see the human being behind the anger. Okay. And we have to acknowledge underlying emotions. Yes, this is a terribly terrifying time for the family. And things can seem a bit overwhelming, and I can understand why you're angry. Okay. Maintain body language um, that conveys receptivity. I'm here to listen to you. If you're standing there with your arms crossed and looking away and all of that, you're only making the situation worse. Be mindful of eye contact, not coming across as a challenge. Okay. Promise to investigate any unresolved issues and to talk again and talk again. When you say that you will talk again, make sure you actually follow up. Okay. And there might be times when you are angry. You need to buy time to bring your own emotions under control. And how do you do that? You offer the other person a glass of water and drink some water yourself. Recognize underlying emotion in yourself as well. Okay. There has to be cohesion within the team. If I am not able to handle the situation, then I should be able to hand over the situation to somebody else. Okay. Do not expect the issue to be resolved with the one meeting. And if you are doubtful of regulating your emotions, please get somebody else to come in. Okay. Don't lose control of the situation by losing control of your emotions. There is no coming back from that. And always try and have a debrief with the team, a discussion within the team of why this person was angry, why were you angry, what led to the situation. It really helps to have that sort of a debrief with your team. Okay. um I know that we did okay, so dealing with difficult emotions, sometimes unfocused anger or fear uh, converted into anger may be directed at you. The best way to deal, be ready for that, it'll happen. The best way to deal with this is to listen without interruption, because it gives them the time to vent. And as ideally, as they keep talking, the energy levels start to settle a little bit. Okay. Some patients become uncommunicative and withdraw. Please consider why that might be. There might be other reasons for it. It could be the medication itself. It could be fatigue. It could be various other reasons. It's not necessary that they are distressed or angry at you. Caregivers often feel guilty, inadequate, helpless. Please acknowledge the positive things that they are doing, because caregivers very rarely get acknowledged. And sometimes just that is motivation that they need in that moment. Please don't make commitments to relieve momentary distress to yourself or to the patient. Make sure that whatever you're offering is realistic and within your capacity to deliver. And hope should always be realistic. It should be differentiated from wishful thinking. And I will spend a little bit more time on this the next time we have a conversation, because wishful thinking and hope is a very, very important distinction to make. And I think that requires a little bit more time than we have today to really go into. So I will just come down to one last slide for the time being. I'm very sorry for going over time today. And we haven't talked about collusion, but what I will share with you is that collusion is basically what collusion is a secret agreement. Okay. And by secret agreement, it is a secret agreement between two or more people who are trying to deceive the third person. So it could be between two family members. It could be between the family member, and then it becomes collusion when they bring the medical team in. In healthcare, collusion implies any information, whether it's about diagnosis, prognosis, or other medical details, being withheld or not being shared amongst individuals. And collusion also means that relevant and complete medical information is selectively or not disclosed at all. So this is where we are gatekeeping. We're saying, no, this person is not ready for it. I will share with you, because we're short on time, I will share with you a particular paper on how collusion can actually be managed. But typically, there are many reasons why we end up not revealing the diagnosis to the patient. And there could be reasons that we as staff have. We don't know our roles or responsibility. It's not my job to tell the patient about this diagnosis. They feel that the family has to decide how, and it's the family's decision how they want to handle it. It's not my problem. If family's telling me not to do it, then I'm not going to do it. There's no support for me to be able to do that decision, to share that information with them, because my other teammates are not cooperating with me. They're saying, no, why are you taking on this headache? Leave it. There could be a language or communication problem, or maybe we just don't think we have all the facts, and then we're passing the buck to other people. These are various reasons. The patient themselves, there might be various reasons why this leads to a lack of revelation of the diagnosis. They may not be able to accept it. They don't want to know. We believe that the patient will lose hope, or the family believes that. They don't have the choice or autonomy to make decisions. We don't ask for their opinions. Sometimes it's because the patient has some sort of cognitive impairment, and we feel maybe that the patient's education status doesn't warrant that they need the diagnosis, which is not true, and the patient is in denial. There could also be other factors, and I'm going to share these slides with you, so please go through them. And so there are many, many reasons why we end up not revealing the diagnosis. There are different ways in which we can deal with this. There are family targeted strategies, where we have to first make sure that the family themselves know the information. We talk to them about the reasons and problems that of collusion. We have to tell them that, listen, if we keep this information from your family member, then these are some of the problems that might arise later. It's always helpful to tell them the process of breaking bad news. I'm not going to tell your family member that they have terminal cancer. I'm not going to be insensitive about it. So typically, this is how we break bad news, and we will be sure to respect the person's capacity to receive the bad news. So just the spikes protocol in a more layperson way, I will say that, listen, we will do it sensitively. We're not going to break it insensitively. And reassuring family members of continued care and support for the patient and for the family. For us as staff, we need to also be more educated in collusion and how to really think about what might be the reasons that are leading to collusion from our side. Appointing clinician champions in the major departments of the hospitals to work for to overcome collusion, bring about some sort of a strategy within the team and say, okay, when this happens, this is the information that the doctor will handle, this is the information that the nurse will handle, depending on the closeness levels and other strategies. So there's a protocol. I will share that with you as well. Sorry to be rushing through this. Now, finally, I will close with this, the basic do's and don'ts. Don't avoid eye contact, but make sure that it's appropriate. Okay. You don't have to rush in to tell the truth. As we saw today, we have to gauge the readiness of the patient. Please don't attempt to answer questions like, when will I die? Or how long do I have? There's a reason they're asking that. So your response there is, what makes you ask me that question? Is there anything in particular that is on your mind? And then get them to open up a little bit more. Okay. And when you say, what makes you ask me that question, they might come up with the deeper level of where they're coming from, whether it's their fear or they're finally letting you know that, you know what, I know what I have is serious. I need to have conversations with my family. I need to put some things in order. Don't ask leading questions. Your pain is better now, isn't it? You ask open-ended questions. Please don't minimize or compare the patient's problems with somebody else. So don't worry. I've seen dozens of cases like this. It's nothing. We'll handle it. That's minimizing the patient's problem. And, Mrs. Sharma, the other lady who you saw in the waiting room, you know how many years she's been going through this and how many family members we've treated. So that's where you're comparing somebody else. Okay, so don't do that. You have to acknowledge that this is their reality and to empathize with it. And please don't give false hope. Everything will be fine. You'll be okay. Give realistic hope. Your disease might be progressive, but we will be here for you and your family. Please don't assume that they're scared. Instead, understand from them what their concerns are. Okay, so various open-ended techniques and all of that are there. And like I said, I'm available to all of you. Sorry to have rushed through this, but any questions regarding any of these, I'm here to answer. Please remember that, like Robert Buckman says, if we do it badly, they may never forgive us. If you do it well, they will never forget us. Okay, but also people remember how you made them feel. And a lot of that is achieved through good communication. So way over time, I'm very, very sorry about that. And thank you for being so patient. And especially sorry to Arya and the tech team in Pallium India, who I'm sure I'm going to get a earful from later. Okay.
It's a pleasure, ma'am. One thing I want to tell you is you asked me to note Dr. Payal Advani's question regarding buccal mucosa cases. Should we deal it now or in private, ma'am? Ma'am, you are muted, I think.
I said, yeah, I'll take that offline if that's all right. We'll take it privately.
Okay, ma'am. Okay.
Right.
Thank you, ma'am. It's a wonderful session as always. No need to specially mention it. Dear participants, such a commendable level of interaction. We'll meet you in the next session. Till then, bye.
Thank you. Goodbye.
Thank you.